Good morning. This is Lana Hunt, IPMG Director of Training and Outreach, and I'd like to welcome everyone to today's workshop on Medicaid Waiver and Hospice Partnership. Before I introduce our guest speakers, I would like to just remind case managers that are attending today that this training has been approved for one Advocare external training credit, and you should submit the confirmation of attendance email that will be sent to you within 2 business days from our public relations email to receive this credit. If for some reason you do not receive that confirmation of attendance email, again within 2 business days, please contact our customer service at the email listed on the screen. And also for everyone that is attending today, within 2 business days, you will receive an email that will have the link to the training recording, the associated materials, and also the question and answer. So you will receive that, and it will also be available on our website at go2ipmg.com, and we'll also post it on our social media sites. So there's a variety of ways that you can go back and reference today's training. We also welcome and appreciate your feedback. So once today's workshop has ended, you will receive a survey. It will launch immediately afterwards, and we would appreciate you letting us know your thoughts and your feedback about today's workshop and about future topics for upcoming workshops. So with that, I am very pleased to be able to introduce Susan Campbell and Crystal Godfrey, both with Premier Hospice and Palliative Care. Susan is the Community Liaison with Premier Hospice, and in her role, she leads a team that provides support in all aspects of hospice, including education, relationship building, and admissions. Susan has 20 years experience in the medical field, with the last 4 years with Premier Hospice. She's very passionate about hospice and palliative care and believes that just as birth is celebrated, so should the journey of life. Crystal Godfrey is the clinical director and administrator for the Premier offices in northern Indiana. She's been in her current role since 2012 and is very involved with the clinical teams in all of the Indiana offices. So I'm very excited that both Susan and Crystal are able to join us today, and I am going to turn the presentation over to them. All right. Ladies, I believe that you should be ready to go.
Okay. Well, we'd like to say thank you to Lana and IPMG for inviting us for this opportunity to share a little bit about hospice and the PA and waiver programs. Anything that you will see today presented will be pretty much the way Premier Hospice does things. So if there is some question about a provider that you use, you would need to direct those questions to them. Contact information is on the home screen there, as well as a fax number. If you have any questions afterwards, I welcome you to call and let me know. We're glad to assist.
Can you all see the screen?
Yes, I believe everyone can see the screen.
All right, sounds good.
Thank you. Okay, so the first thing that we'll go over is the Medicare set guidelines. Hospice is driven by Medicare, basically, so our guidelines and the rules that we follow are set by Medicare. Physicians have to certify terminal status of the patient. Basically, you're looking at a 6-month prognosis. No, we don't have a crystal ball, so sometimes that 6-month window goes a little longer. As you all know, patients decline at different levels. That is just something that Medicare, looks at 6-month prognosis there from the physician. The benefit's designed to continue past 6 months, and we have to go through criteria to make sure that patient continues to qualify. Basically, you're looking at a decline in condition, no matter how small or how large. All hospice staff, in addition to medications, treatments, and DME, is covered under the hospice umbrella, which that's what I think a lot of people don't understand. Once hospice is called in, that hospice company does take care of getting any equipment, medications, things like that to the patient and the family. Equipment includes anything from walkers, wheelchairs, bedside commode, shower chairs, oxygen, hospital bed, etc. And again, you will need to have contact with your hospice provider as far as what equipment they will provide. This is basically just a window of what is covered under that umbrella. Staffing-wise, nurse visits, again, this is Premier's guidelines that we follow. Nurse visits are between 1 and 3 times a week, depending on the acuity of the patient. We obviously increase those daily as per lines, and on-call is available 24/7. With Premier Hospice, we do have on-call staff that is just for that purpose. Home health aides provided usually 2 to 3 times a week to assist with showers, feedings, etc. We do service those patients that are in nursing homes, assisted livings, so those are all guided as well with the home health aide. Social worker, chaplain, volunteers are also called in the Premier team, and bereavement support is provided for 13 months after a patient's passing. That includes phone calls, meeting them for coffee, cards, any way that we can help that family with the grieving process is very important. As you know, people grieve at different levels as well. 24-hour on-call. Through Premier Hospice, our nurses are available 24 hours a day, 7 days a week, 365 days a year. We like to be notified with any major change of condition, pain, nausea, agitation, shortness of breath, just anything that is not the baseline for the patient. Chaplains and social workers are also available on call to support patients and families should they need those services as well. A couple things just to think about and remember when you're talking with a family about hospice. Asking for just the screening does not commit anyone, the patient, to any particular hospice group. What it does is it allows the hospice group to clarify the patient's condition, assist the power of attorney or the guardian or whoever it may be, understand the benefit of hospice, and to increase the comfort and peace of mind. I think just from a personal level, meeting with families and being able to sit down and discuss hospice and take the fear away from them is a huge benefit. And hospice is one of the most underutilized benefits, and honestly I feel like it's because of the word hospice. Most people are afraid of that. So if you could set those fears aside and let them know what the benefit is, it's much better. The journey with Premier, and again, this is just something that Premier does, so you'll need to reach out to your providers. Meeting with the patients and families where they're at in their journey, and that can vary from family to patient, obviously. Not always do you find the patient and the family on the same page. You know, patient might be ready, but family's not. And that's where it's real important to have that sit-down discussion with that family and the patient to explain to them the whole benefit of hospice. 24/7 referrals and admissions, 7-day visits for hospital discharges to home. That's another way just for that peace of mind and continuity of care for that family taking their loved one home, where they're used to having nurses there all the time and caring for that patient. So sometimes the anxiety does raise once you discharge to home. Rehospitalization scoring for daily evening phone call checks. We do this for our patients just to help keep the anxiety down, answer questions, A lot of questions come up once the patient makes it home. Visits with change of condition. And really for the hospice field, everyone needs to be proactive versus reactive. You need to be able to, anticipate what those needs are going to be in the home for that patient and kind of see the vision of where their journey's taking them. Another thing with Premier, we accept all insurances and the unfunded as well. Specialty services, and we also have several general inpatient, which is the GIP, and the skilled nursing facility contracts. So pretty much wherever that patient is, we can help service them and bring them services of hospice. Some of the guidelines that we look at, I'll let Crystal cover that. She is our clinical, so I'll let her go over that with you.
So anytime a patient is referred to hospice, they do get an evaluation. We want to make sure that they qualify. So one of the things we ask for and the things that we're looking out for is just seeing one or more of the following there on the screen. We look at weight loss. Has the patient had recurrent infections, pneumonia, UTI? Any frequent hospital trips into the ER? Were they admitted? Any decrease in ADL performance? Maybe they were pretty independent, now they're minimal maximum assist, or maybe they're even total care now. We also look at oxygen. Are they using it more often? Are they now on it full time? All of our respiratory patients we look at, we want to make sure that their O2 stats are at least below 88% in order to qualify them for respiratory. We look at also, do they have any increased heart or lung symptoms? Maybe they're having chest pain, they're taking their nitro more often, more shortness of breath, no longer able to ambulate as far as they were, or just getting shortness of breath conversing. Okay. So, like Susan was saying earlier, we try to be proactive versus reactive. And this is something else that's specific to Premier. What we offer each of our patients is the full package. So what that means is we try to get at least all of the equipment that we can foresee the patient's needing while they're in their journey right up front in the home. So it's not a scramble at last minute at 2 a.m. my patient needs oxygen. So we want to make sure that we're addressing those needs right away. They may not use them. They may not ever use them. They can just tuck them away. But we do the electric beds. We can put side rails on if that's an option for our patients. Of course, wheelchairs, rollators, overbed tables, shower chairs, bedside commodes, and also oxygen. All of our equipment can be delivered 24/7. We do get a 2 to 4 hour time frame window for our patients. So comfort care comes in many forms during the journey. So when we look at this, we talk about the different things that sets Premier aside. And again, this is specific for Premier, so you'll definitely want to reach out to your organizations that you use. We use our Airvo machines. We use a little bit more than just our traditional oxygen now. We've noticed that our respiratory patients may qualify for hospice, but may need to have a little bit more in order to get them home or to keep them comfortable. So we have had the ability to use the cough assist machines. We do CPAPs, we do BiPAPs, and we also have the VPAP. For our cardiac patients, we also do dobutamine drips as well. Sometimes that's what they need to get them home, and sometimes that's the only way to get them home out of the hospital in order to meet those needs of the patient and the family. We have done palliative radiation for our patients as well. And we also do terminal vent weans, and we use Trilogy machines. Again, this is specific to Premier, and one of the reasons we do this with our families and our patients is just due to the journey. Not everyone comes to hospice at acceptance. Not everyone comes to hospice clear, black, and white. It's very gray, and we feel like it's very important to meet them where they are and get them down that path.
Okay, so some of the Medicaid services and hospice, Medicaid Waiver. contrary to what people think, you can utilize Medicaid waiver and hospice services. It can be something that is offered to a patient. What happens is, and it gets kind of tricky, I'm not going to lie, so you have to be very specific when a patient has waiver, and the key here is communication. The key is communication with the hospice group and the waiver service provider. A lot of times how we do this is not utilizing our home health aid, because most of what I've seen is patients that have Medicaid waiver can have anywhere from 2 to 4 to 6 to 8 hours per day having that home health aid in the home. And so what's best for the patient is to have those hours versus the home health aid through hospice, because our aid goes in, does the bathing, grooming, those kinds of things, but is sent, you know, only there about 45 minutes to an hour per visit. So what's best for the patient is obviously to use the waiver home health aid. We do prefer on the hospice end, whether it be whichever hospice group, to use a different diagnosis than the home health agency, if possible. It's not required, but it does make things easier. For instance, if you have a patient who has end-stage CHF but also has debility, hospice team would pick up the end-stage CHF, whereas home health could bill for debility. So you want to keep those two things clear just for billing purposes. And hospice should take the rein to call the home health to coordinate services. We should also contact the Council on Aging and those kinds of things. That's not something that, as a case manager or whatnot, that you feel that you should have to do. That should be the communication of the hospice liaison and the home health to take that off your plate. We also share plan of cares. It's real important for the hospice team to know what the plan of care is for the home health and vice versa, which only makes sense. You've got that common denominator of the patient in mind. Medicaid PA can sometimes be provided. That is something that, again, the key here is communication. We would also, on the hospice end, not send in the home health aid, because you don't want to jeopardize those PA hours. You want to keep those in place because, again, that is a benefit to the patient. If Medicaid PA is paying for the nurse hours, the nurse on the home health side needs to be discontinued. Basically, you're going to utilize the hospice nurse, but the home health aide. So that way there's no duplication of services there. And with the PA, we must use a different diagnosis. Coordination of care is very important. And what I found is, just in my own personal experience, a lot of the home health agencies are hesitant to actually bring on hospice due to the lack of communication in the past. Because if you don't have the different diagnoses set and the coordination of care, that's where the billing issue comes in for home health and them getting paid. So again, it's very important to have communication between the hospice liaison and the home health agency. We did put a number up there to call for Medicaid. The home health agency, they actually turn in the contract with the local council on aging just to get approval for our services. And again, there's a must that we have to share a plan of cares. Again, it's continuity of care for that patient, and you have dual billing issues, and therefore everyone needs to be on the same page as far as plan of care. So with Medicaid waiver and PA, it can be tricky at times, but it is definitely doable, and it would be a great benefit to the patient to be able to utilize end-of-life care with those waiver and PA hours. So if you have any questions about that, feel free to reach out. Just some examples of clients currently receiving services. Kind of let you guys read through those for yourself and just kind of see But the first one, the client receiving home and community-based services may elect Medicare, Medicaid, hospice benefit as deemed eligible. Case manager may request additional home and community-based services as long as they are not duplicative of hospice. That's one thing that we just have to really watch, is not duplicating the home health aide or the nursing services. But again, that would come into play with the communication between the hospice team and the home health team. So I'll kind of let you read through those examples at your leisure. Here's a couple more on the next page. And then we've also included the website there for you to download some info as well, just some criteria and such. Some of the hospice diagnoses included under the Medicare specific guidelines, the unspecified protein calorie nutrition before we had the adult failure to thrive, and that was a diagnosis that Medicare kind of did away with, but you know, with the protein calorie malnutrition, that is one way. There has to be certain criteria met for that, obviously. ALS, dementia, lung and heart disease, stroke and coma, liver disease, renal, cancer, HIV, and AIDS. So again, these are just some of the things that you look for in a patient for a hospice referral. A couple things to remember. Refer the patient and family early to get the true benefit. And again, that comes in with your waiver and your PA patients. Those patients that have those services usually have that decline, usually have that life-limiting illness that really hospice could be brought on and add a benefit to them. Focus on words like supportive care versus hospice. And one of the things that I found is family a lot of times says, well, my loved one doesn't qualify, they don't need hospice, they don't have cancer, or they're not going to pass away immediately. And that's some of just the myths of hospice that we run into on a daily basis. The hospice focus is really staying ahead of the disease process and does not speed up a patient's passing. That's another thing that we kind of deal with. You know, people feel like, well, once they come on hospice, it's a quick transition, and that's not the case. This is our sweet little lady there. She just brings us joy, and looking at that smile on her face. But hospice affirms life but never denies death, recognizes dying as a normal process of life, honors wishes, offers choices, brings commitment and compassion, strengthens families. It's about faith, hope, and caring. And that is really should be the philosophy and the centerpiece for any hospice group that you work with. Something that Premier offers is just kind of a journey. It's just where we can really zone in on these patients where you might need assistance with, or just a quick eval, see if they're appropriate, if they're not appropriate. Your hospice teams that you're working with should be just an extension of you, be able to give you guidance, and you know, especially if you have a family that's not quite ready to make that decision for hospice. We meet the patients and families where they are in their journey, and like I said previously, you know, sometimes patients ready, families not so much, but helping them plan for the just-in-case scenario is just being proactive versus reactive. Pulling in resources to help, that's where your Medicaid waiver and PA, you know, come into play, and being able to utilize those benefits along with hospice to get the patient the most services they can get in the home setting. Just really building that relationship. Home patients are people that would be a journey patient, would be the ones that are receiving curative care but meet criteria. So maybe you have a cancer patient who's still going through treatment. Works with the hospital and clinical staff, meets with the family just to answer questions. You know, a lot of times the families I meet with have no idea that hospice benefits are paid at 100% by Medicare and Medicaid. they have no idea. So that's another thing that just by having that sit-down conversation with the family. As I said before, patients that are in the skilled nursing facility, those are patients can also utilize hospice benefits. Your Medicare patients that have extinguished all their Med-A days, you know, they're probably, unless they have a second payer source, are going to be private pay, whereas they bring on hospice. Hospice can bill Medicare for our services, so they're getting extra care while they're private paying for their stay. So it's just extra support for everyone. And also with hospice, for you case managers that work in the hospital setting, it really helps to decrease the rehospitalization. You know, that's a main focus right now for a lot of the hospitals and facilities is the rehospitalization piece with Medicare. So hospice is something that can really help the patients through that. Basically for the journey, just a referral to the liaison, information, H&P, those kinds of things are needed just so we can make contact and just be able to facilitate with the family. With Premier, you know, our goal is providing quality hospice services wherever the patients call home. So home, assisted living, skilled facilities, wherever that may be. I mean, we have patients in group homes. We have patients that have lived at a mission. And our goal is for the whole team to get involved and really be able to utilize services for that patient and really help them through their journey. Our goal is to prevent extended hospitalizations and rehospitalization, obviously, by providing top-notch innovative services. And that's where a lot of our clinical piece comes in. So with Premier, like I said, any questions, concerns, Crystal or I will be happy to answer. And any questions with waiver and PA, please ask. Please reach out to your hospice contacts that you have. Our number's there. If you guys have any questions, please let us know.
Thank you so much, Susan and Crystal. That was very good information. And I know that, you know, we have individuals that receive services through the Medicaid waiver that may be at that point where they would be considering hospice services. And we do have some questions, so I'm going to bring those up and we can get started going through them. First is just someone that is saying that they personally had an experience with hospice and it was very much appreciated. It was a great support to them. Someone is asking, in what counties in Indiana does Premier serve? Do you have specific areas or are you statewide?
We are pretty much statewide. We are only in Indiana. We have 3 hub offices currently. We have an office in Seymour, which handles the southern part of the state. Carmel, which services the mid-state. We have an office in Kokomo, and then we are getting ready to open an office in Fort Wayne. So the great benefit of that is covering the whole state of Indiana. What I found is, you know, if patient lives in Muncie, Indiana, but their daughter lives in Fort Wayne and they want to be able to transfer care, that's not a problem. So we really utilize the whole state of Indiana. There's a few counties that we're not in yet, but nothing significant.
Okay, great. Someone has asked for a little bit of clarification on, I think you had mentioned the waiver home health aid, and I think what you were meaning is that there are quite a few individuals receiving Medicaid waiver services that also receive services through a home health care agency. That funding is also different. So I think in those situations you would want to work with all agencies. So as you both mentioned several times, that communication is very important. So if the Medicaid waiver provider is providing residential habilitation services, and there is a home health care agency also providing a home health aid, and the hospice becomes involved, those three groups would definitely need to work collaboratively and communicate with each other throughout the process.
Correct. Communication is key. I have personally helped with several patients that have Medicaid PA and waiver with no hiccups. Basically, it's just the communication key, so that everyone knows who's going in, who's doing what, and who's caring for that patient. So it's definitely the communication is the main key in that, definitely.
Right. Perfect. Okay. Someone has said that Medicaid is obviously considered funding of last resort in Indiana, and they're asking how can you utilize Medicaid when Medicare would cover the cost of home health through hospice? So I guess the question is, if hospice is able to provide home health aid, would that not want to be the first funding source? And you all would know maybe a little bit more in regards to those guidelines for Medicaid.
Yeah, so Medicaid, of course, does the PA and the waiver. So I want to make sure we do make it clear, you know, for home health companies, they're not actually in there providing the full service of home health care. So what they're usually doing is using one of their home health aides in there, their CNAs, and they're providing those hours. Now, because hospice is being billed through the Medicare portion, we are required to offer our home health aid. So what we do is, of course, we offer it, but the patient has the right to choose to keep their aid under the waiver PA hours and not use the hospice aid.
Okay, that's very good information. I'm sorry, I'm just typing that in, so just 1 second.
And you know, that question does get brought up quite a bit because Medicare does require hospice to offer those services. It's just the patient or the family's choice.
Okay, very good to know. And that's nice that they're able to do that because they may have a relationship built with that person that's providing that piece of it, and to be able to continue with that if that's their choice is great.
And most of the time that is the situation. There's a relationship built, but there's also more hours being offered, you know, by that home health agency that's providing that for a PA. And so as a hospice group, you want what's best for the patient. So if you have a waiver aide going in that can be there 4 hours a day, that way outweighs the benefit of a hospice aide who's there 45 minutes to an hour. So we want what's best for the patient as well. So it's just the communication piece.
There are a couple questions specific to a service that is offered through the Medicaid Waiver Program called a wellness coordination. I'm not sure if either of you are familiar with that. It is a fairly new service that is available to individuals that qualify if they receive Medicaid waiver services based upon their level of medical need. And the question is, if an individual chooses hospice services and qualifies for hospice services, would that wellness coordination service need to be removed from their waiver plan of care or their waiver services because it may be considered a duplication? Not sure if either one of you have had that experience before, and that may be a question we need to ask the Medicaid waiver unit. But if you have any information on that, I'd be glad to share that with us.
I'm not as familiar with that specific program, but I will definitely say I would reach out and ask those questions. But, you know, it kind of goes back to that same thing with duplication, which was part of the question being asked, is we definitely want to stay away from duplication of services. So if in that program they're providing some skilled care, we would definitely have to evaluate that and make sure it's not what we would be providing in the home.
And we will, just so for anyone else that maybe has that question, because I know we did have a couple of them, IPMG will submit that question, and we'll do a little bit of research into that. I would believe, well, I'm not going to say because I don't know. So just in what you had said, that if they're providing, care, which really this is more of a coordination of wellness and doing some reporting on different types of things. So we will definitely check into that and provide that information, hopefully prior to posting this information, but depending on how long it takes for us to receive that clarification, we will definitely announce that either through our announcements for our employees, or also when we share this information on our newsletter. So,
okay, that would be great.
There is a question asking if an individual is discharged from the hospital, but their waiver home, so the home that they live in where they receive Medicaid waiver services, is not equipped to support the hospice process. Is there an inpatient option, and how do they qualify for something like this? So I know some hospice providers do have an inpatient option. Is that something that could be pursued for individuals receiving Medicaid waiver services if they, for whatever reason, are not able to return to their home?
Well, personal experiences I've had, I have a facility that's actually a waiver assisted. It's an assisted living. But what happens is if they're not equipped with staffing or such, that's where our team really comes into play, our social worker, to be able to help communicate and facilitate finding placement for that patient. So that's where the team is really, really involved. On a Premier aspect, again, I'm speaking from experience with my team, but that's where our team would come in to be able to help with placement for that patient.
And we do offer general inpatient, and again, you're going to want to reach out to your hospice providers to find out, if they have specific inpatient facilities or hospice houses, so-called. We have contracted with several different hospitals in our areas to cover the counties that we service. So if we do have issues with our patients or concerns do come up that can't be maintained in the home, then they do have that alternative route to look into.
Exactly. I think, again, it goes back to having that communication and also looking at things proactively. If at some point in that journey the patient or the individual is not able to remain in their home, what are those options, and ensure that the entire support team is working together on those.
Right. And that's an important piece of the liaison from my perspective when I meet with a family, to actually see that whole picture. If a patient lives alone or, in a situation where there's not anyone that's there checking in on them daily or doing those kinds of med checks and things like that, you definitely have to have that proactive approach with the family, so you can kind of get those wheels turning, because it's not something that you can address after the fact. It really needs to be discussed in that initial meeting.
Yes, absolutely. This is a very interesting question. Someone has said that they noticed that Premier offers music therapy, and have you had any experience in collaboration or transitioning services between music therapy that's offered through the waiver and those offered through hospice services? Have you had any experience with that?
We haven't personally had experience with outside music therapy through the waiver hours. Premier Hospice does have a certified music therapist, not just a chaplain or someone that sings. She is definitely certified. Wonderful. And it's definitely been a huge asset, and it's a benefit to patients. I think it goes back to that myth again, when even physicians, nurses, patients, and families think, you know, hospice is going to come in and give all of these medications, but sometimes it's that music therapist that can come in and control that anxiety for us.
Absolutely. And music therapy, I know through the waiver program, is very popular and has so many benefits. And I think, again, in regards to, you know, if an individual is currently receiving those services through Medicaid Waiver, and that is a service that hospice provider offers, having that communication in advance and understanding, you know, going forward, is it something that the hospice provider would continue to do, or again, because they have already that relationship, maybe that's something they would want to continue with their waiver music therapy provider. Also, I'm assuming, and Crystal or Susan, you can maybe ask this, that, and that's music therapy provided through hospice, I'm assuming would be provided in the patient's home or where they are receiving hospice services?
Absolutely. We have, yes, home patients. I actually have some patients that are in a skilled facility, and our music therapist will go see our patient, and the patient will want her to play down in the commons area so all of the patient's friends can enjoy. So that happens very often. They like to share the enjoyment of the music therapist, and Cheryl is very personal, so she really knows a lot of genre of music, and she also, you know, has attended some patients that have been actively passing, just to bring anxiety down and just be able to soothe the family and patient. So there's several dynamics of how music therapy can help, absolutely.
Very nice, very nice. And the reason I asked that question is because the music therapy service through the Medicaid waiver, it is dependent on the provider. So some providers do provide that service in an individual's home, and some are only agency-based. So again, that is something I think each individual team would want to discuss and look at all of those options.
Right.
I did have someone wanting to thank you for this information. Also, they had a personal experience with hospice and found it to be a great support. They also are working with an individual that will be moving out of the facility next week into supportive living through Medicaid waiver services, and that individual has been diagnosed with stage 4 cancer. And so the team knows that hospice services is something that he will eventually need. So, again, thanking you for the information because it was very helpful.
Well, thank you. Again, we're just honored to be a part of it and just educate and help those that, you know, we want to be a resource to the case managers, to the social workers, to anyone who needs just that information on hospice, because it's such an underutilized benefit and it has such a huge benefit. So any questions that we can answer, we're glad to do so at any time.
We do have a question regarding individuals that are receiving hospice services have often chosen to implement the DNR or do not resuscitate. And it seems that waiver providers are not able, and I want to say this, I think there are some policies in regards to waiver services that would not allow that to be honored. So if a Medicaid waiver service provider is the one providing the care in the home, they would be required to call 911 instead of honoring maybe that DNR. So I don't know, have you had any experience with that or have worked with any families or patients that have received both types of services and how that situation?
Yeah, so we haven't been in a situation per se where the actual home health agency has stated that. But definitely we have some of our patients are full codes, but they typically will give us a call first. If we can sense that it's a really anxious situation, we may go ahead and say proceed with that, and we'll just meet you then at the hospital versus coming to the home. So it's definitely a case-by-case basis, but not personally have we come across where we were told that that was something that the home health had to do.
Thank you. I was just typing, so let's see. Again, thanking you for your presentation and for sharing this information. And, you know, it is something I think that both of you said this, you know, it is a journey and it is part of life. And so being able to have services and supports to plan and support those individuals that are at or may soon be at that point in their life where hospice services can benefit them, and helping to educate the families that we work with and individuals that we work with on this service and how it can benefit them through that process, I think is very important. So we do definitely appreciate you two being able to join us today and sharing this information. As Susan mentioned, the contact information for Premier is located on this presentation, which again we're going to be sharing. So if you have any specific questions, I know that they would be glad to speak with you. Also, we will take a few of the questions that we've received and try to receive clarification on those and provide that information as well. So thank you both again very much. I do, just as a reminder, again, this information will be made available to everyone that attended today. We'll be sending out that email that will have the link to the recording as well as the information that was shared in the Q&A, and we will also post that on our website. I would also like to share that next month on September the 16th, we will have our professional development workshop that will feature Kathy Boswell from InSource, and she will be providing information on preparing for the Special Education Chiefs Conference. And that's, I think, very timely information considering school is most likely back in session for almost everyone. So please look for that information to be announced very soon. Again, that will be on September 16th at 11:30 Eastern Time, and that information will be posted. It has already been approved for case managers through the Advocare external training, so you can also register that way. Thank you, everyone, for joining us today, and again, thank you, Susan and Crystal, and I hope everyone has a great weekend. Thank you.
Thank you.